believe as an organization that a health plan that's going to be successful in the future can't just do contracting. It has to be a partner, it has to be a collaborator with the delivery system, because in order to maximize value, you have to both be concerned about quality, but you have to be concerned about cost as well. And so a partnership is required. Things like data sharing, analytic tools, perspectives that we have on underwriting and informatics and analytics are all very valuable if you're going to be a delivery system focused on value-based care. Healthogen was created to bring all of those various assets together that Aetna has developed over its history and focus them specifically on the provider community. And so it's both a point of focus as well as an incubator. We come up with new ideas, new strategies, new capabilities, new programs that are particularly valuable in the fee-for-value world. Well, it's really a complete disruption of how healthcare is bought and sold. Traditionally, a health plan would execute something we might call the first sale. You sell the employer group, and there would be a group of employees, and you would understand their characteristics as a group, their age, sex, where they live, diseases they might have, and you might be able to price to risk. But as you move more and more into a consumer-based world, that entire sales process begins to get disrupted. And it impacts every single decision point. For instance, the provider network. If I'm selling to an employer, I have to create a provider network that is suitable for all of their employees. Otherwise, that company's not gonna buy it. But if I'm now in a retail environment, I can develop individual products for individuals. And so if it isn't, if we don't have facilities, if a particular product doesn't have facilities in your particular geography, it's okay. It applies to the people it applies to and doesn't to those that it doesn't. But I think there's, looking a bit farther to the future, I think there's grounds to believe that you may see even more innovation coming from this change in how healthcare is bought and sold. For instance, no one's ever commonly built health plans for diabetics, health plans for people with renal disease. And yet when you think about that, theoretically, having a focused factory type of approach where you build a certain expertise in managing a certain disease, we know actually makes a lot of sense. So I think we've really just begun to see the cusp of innovation that's going to come forward by the move to a retail type of sales process. Well, the intersection between population health and individual health at first blush seems somewhat inconsistent, right? But they do come together in a way that makes sense. First of all, when I am a delivery system or provider of healthcare services, I have to look at myself as a care system. I have a suite of services designed to keep people healthy, well, or if they're ill, correct their illness or at least mitigate it. Well, in order to do that, I need to have a certain set of services, a certain set of infrastructure, a certain set of capabilities. Well, that set of capabilities and infrastructure serves a population. So there are a whole set of things we can do on a population basis that in the old world we never did. For instance, we look at avoidable ED visits. Pretty straightforward metric to create. And to give you one example, we had a ACO client that had the highest number of avoidable ED visits we'd ever seen. And normally, we might note that metric, but in an ACO model, we took that metric to the delivery system and we said, hey, what's going on here? There's something really wrong. And they said, oh yeah, we know that geography and that there's a clinic there and it's overrun with patients and it doesn't surprise us. And we said, well, let's dig a little deeper. It surprises us. Well, so anyway, when we went out, sure enough, the clinic was overrun with patients. It wasn't particularly managed well, but what had happened was the front office staff during normal office hours, these were avoidable ED visits during normal office hours, which we typically don't see them that high, had put the phones at the clinic on forwarding to the answering service. So what happens when you call and you need care and you get the answering service? Go to the emergency room. They were preferentially referring to the emergency room at a rate so high it showed up at the in the claim data. Those are the kinds of insights that you can begin to create when you take a population-based approach. Here's a suite of services, here's a population of people you're trying to treat, let's see how the two interact. But at the end of the day, healthcare is still about managing the individual. And there are individual sets of decisions that need to be made, and they need to be individualized for each patient. So I look at it as kind of two reflections of the same process. One on the population health side is infrastructure, programs, assessments as to how I'm doing. The other is the individual patient within that mix. And you really have to have both in order to be successful. We have a whole series of metrics we look at to say whether a delivery system will be an effective ACO. For instance, breadth of services, right? If they are managing, let's say, 80% of the services needed to service a population, that's usually a good thing versus someone who only has 20%. Do they have a brand name that people recognize and respect and know in the community? Do they have the appropriate technology infrastructure in place? There's a whole series of individual metrics. How do they perform in their current state? Some delivery systems are inherently efficient for whatever reason, and it's very easy to predict that they'll do well in an ACO setting. Others are not. But probably the most important metric is the executive leadership and the clinical leadership of the delivery system. If they are not committed to value-based care and ACO-style operations, nothing else really matters. So if the leadership is there, I would put it this way, I would rather have very strong management on the clinical and administrative side committed to an ACO and value-based care than an ACO that wasn't committed, or a delivery system that wasn't committed but had good metrics.